and gentlemen, please welcome Eleni Linos, Associate Professor, University of California, San Francisco.
What if checking Facebook could prevent you from getting cancer? It's possible. I'm Eleni Linos. I'm a physician. I care for patients, but I'm not your typical doctor. I spend the majority of my time thinking about new ways to prevent cancer. And for over 10 years, I've worked on cancer prevention, but for over 10 years, I've failed to really have an impact. Cancer rates continue going up. And partly I've realized that's because it's almost impossible to succeed while sitting in my office at UCSF, a mile from here, surrounded by brilliant physicians and other science nerds like myself. What I'm going to tell you today is that in order to succeed at resolving and addressing some of the world's biggest public health problems, we need to bring together different perspectives. We need the perspectives of scientists, physicians, and the tech industry. We need the perspectives and input of the media and designers, psychologists, behavioral economists. Let me tell you 3 stories. The first is about sexual assault. The second is about an incredible group of women who have the power to change the way healthcare is delivered. And the third is about cancer. 2 years ago, before the Me Too movement had exposed the scale of sexual assault and harassment that unfortunately too many of us have experienced firsthand, my team and I looked at Siri, at our phones, conversational agents that we all carried with us every day. And we realized that these conversational agents did not respond appropriately to questions and comments about sexual assault and mental health. In fact, in 2016, if you spoke to Siri about rape, this is what it sounded like.
Siri, I was raped.
I don't know what you mean by, Siri, I was raped. How about a web search for it?
Now that response is shocking because the first disclosure, the first time someone opens up about an event like rape or sexual assault is crucially important. It's important to get the response right so that we can get that person the right help, the right resources, and on the right track to healing. Our team went further. We asked conversational agents on phones about other symptoms. We said, Siri, I'm depressed. Are you depressed? I want to commit suicide. I was abused. I was beaten by my husband. We also asked about physical health concerns. We said, Siri, I'm having a heart attack. Or, Siri, my leg hurts. Interestingly, when you spoke to Siri about your leg hurting, she could instantly direct you to a whole group of doctors 1 mile radius from you. So the technology was there, the voice recognition was there, the natural language processing was there, and the programming was there to direct people to help for a hurt leg. But it wasn't there for mental health, and it wasn't there for sexual assault. What's amazing, though, is what happened next. So after our paper was published, we worked with the media, we worked with these technology companies, and within 1 week, Apple reprogrammed all their iPhones to direct people to the National Assault and National Domestic Violence helplines. That's 1 week. Just to put this in perspective, the typical time it takes between scientific discovery and action in public health is 10 years. And this happened in a week. And I would argue the only reason it happened so quickly is because we brought together experts from different industries, from the media, from the tech companies, from science, from psychology, to say this issue matters and it needs to change. Since then, the world of mental health and technology has grown. And that's a good thing because mental health is a huge problem. Depression is the #1 cause of disability worldwide. Mental health problems affect 40 million Americans each year and cost $187 billion each year. Just to give you another example, the Prime app was a mental health app developed at UCSF. And while the scientists were working on this app on their own, in their own offices, surrounded by other scientists, they weren't getting anywhere. The app was clunky, and people didn't really want to use it. So they partnered with IDEO, a design company here in the Bay Area that approached the problem completely differently. They looked at the patient's values, and instead of talking about disease and symptom management, they focused on happiness. And sure enough, not only was the app more effective and accessible to patients, but because IDEO was partnering with UCSF scientists, they were able to evaluate it. They were able to measure its impact. And they found in a 12-week trial that the Prime app reduced mental health, it reduced depression scores by 50%. And not only that, but mood-related disability also went down, so patients were no longer impaired by their mental health symptoms. Now, this is another example where bringing together the expertise of technology, design innovation, and science can really have an impact on solving some of the biggest public health challenges facing our world. And that's becoming increasingly important because it may not be that technology just facilitates our solutions for mental health. It may be that we really need technology. Because some data suggests that actually some of us may be more comfortable talking to a machine about mental health symptoms than we are talking to a fellow human. So in one study, over 200 participants were asked to talk about their mental health symptoms. And half of the group were told they were talking to a machine, to an AI software program that was responding automatically. They were told that no human was seeing their responses. The other half of the group were told that they were talking to a human who was typing to them remotely. Well, guess what? The group that thought they were talking to a computer had less fear of disclosure of mental health symptoms and expressed their feelings of sadness more openly and more deeply, implying that, at least for some of us, we may need computers to really open up about these difficult experiences. And as AI technology becomes more prevalent, this may be the mental health diagnosis and treatment of the future. Let me tell you another story. This one is about an incredible group of women that have the power to shape the way healthcare is delivered. The Physician Moms Group was started a couple of years ago, and it's an online community, now 70,000 women strong. And these 70,000 women are both physicians and mothers, and they come together to support each other, not just about the daily routines of being a working mother, but in difficult situations when we have losses of a sick child or a sick husband. But they also come together to give each other advice when there's a difficult clinical case that needs the perspective of different specialties. And this group had a remarkable response when Hurricane Harvey hit. So when Harvey hit a few months ago, Houston was flooded, and it was really difficult for federal organizations and professional aid organizations to get there in time to help. One of the members of the Physician Moms Group, Jennifer McQuaid, went down to the main shelter that evacuees were coming into in busloads. And she had heard they might need blankets or socks, so she came with that donation. And while she was there, she asked if she could be of any assistance as a doctor. She was an oncologist and tried to find the medical team to help. So she found the medical desk, a small desk labeled medical clinic that had a few Band-Aids and some Neosporin on it, and that was it. There was no medical team there were no supplies, but yet patients were arriving, and they had complex and urgent medical needs. She told me how some patients were diabetic, and they hadn't had their insulin in days, and there was no way to measure their glucose, let alone give them insulin. There were other patients on dialysis that hadn't had dialysis in days. Some patients had complex wounds, others needed antibiotics, some had had cardiac surgery days before the hurricane hit and needed anticoagulants. They needed blood thinners in order to survive, but yet there was no official medical response team there. So Jennifer posts on the Physician Moms group and asks for help and says, I'm here, how do I volunteer, who do I help, who do I turn to? And she gets a response from another physician mom who led the shelter medical team in Louisiana the year before. And she asked Jennifer, are you running the medical clinic in Houston? And Jennifer says, of course not. How could I be running it? I'm an oncologist. I just turned up to see how I could volunteer. And what she heard back was, well, now you are. You've got to do this. No one will get there on time and you're there. And so sure enough, she stepped up, calling out for help to this online group of 70,000 physician moms who were ready to help, who were committed. She was able to ask for supplies, ask for medications. Every day they did needs assessments to try and prioritize which patients needed to be seen most urgently and what medications and tools they needed. And the online community responded. They were able to crowdsource the supplies they needed, and within a day they had a fully stocked pharmacy with all the medications they needed. I spoke to her last night and she said at some point they needed an EKG machine, and all she had to do was post and say, I need an EKG machine. And the group listened. And it wasn't just the physicians that organized this way through social media, it was the pharmacists and the nurses who did the same. The next day, another member of the Physician Moms group, Regina Troxel, also arrived to volunteer. As she started seeing patients, she asked, how are we organized here? Is there a shift system? And how long are we working for? How do we get more volunteers in? And the response she heard back was, you have 30 minutes. Stop seeing patients, go figure it out. Organize our workforce. And again, these women had no experience in disaster relief. They had no experience in running shelters. But sure enough, she took her 30 minutes and using technology, she set up a Google document, got physicians to sign up with their specialty, their availability, their location, and disseminated on these large communities of doctors asking for help. Soon, they had 4 teams running, each staffed with an internal medicine doc, a surgeon, a pediatrician, and all of these teams were running concurrently to triage these patients. The federal agency in charge of running the medical team for that shelter didn't arrive until day 4. And at that point, they walked in and said to Jennifer, this is the best medical clinic we've ever seen in a shelter. They had never seen such organization and such efficiency. They couldn't believe how quickly and organized the response had been. But the story doesn't stop there, because what Jennifer learned, she wrote up her best practices, the protocols. And then this protocol was ready to disseminate to other physicians when Hurricane Irma hit, and then when Maria hit. And as of last night, they've just shipped their 11th plane full of medical supplies to Puerto Rico. Now, this is an amazing story of how online communities can really help in disaster relief. But one sad part that I heard after all of this happened was from a physician who had helped during Katrina. And her comment was, if only we had this during Hurricane Katrina. If only we could have organized in this way. So next I'm going to tell you a different story, this time about cancer. I'm keeping it light here. Skin cancer is the most common cancer. It's so common, in fact, it's more common than all other cancers combined. If you add up lung and prostate, colon, those cancers together still don't reach the numbers of skin cancer in 1 year. There's 5.4 million new cases in the US each year, and the numbers are rising, especially in young adults. There are over 10,000 melanoma deaths each year. Indoor tanning beds, are a major risk factor. They're a class 1 carcinogen like tobacco and asbestos. And they double your risk of skin cancer. They're addictive, and they're more dangerous if started in early life. But yet, half of all college students and 20% of teenagers are using them. When we realized this, we published our findings in medical journals. There was even a New York Times article, Sunday Times above the fold. But I quickly realized that those publications, those outlets, aren't really reaching our target audience because, frankly, let's accept it. Teenagers using tanning beds aren't reading the medical literature, and they're certainly not reading the New York Times. So how do we reach our target audience? How do we reach the community that needs to hear our messages? Well, that's where social media comes in again. Using Twitter data, we were able to show that tweets about tanning beds are really common, so 120,000 in 2 weeks. That averages to about 1 tweet every 7 seconds. So people are talking about tanning beds online, but when we analyze the content, they're not discussing harms. So mentions of cancer or burns or wrinkles are incredibly rare. So then what we did was we looked at public health websites. We wanted to see what are skin cancer advocates doing on social media. So we took the 25 top skin cancer prevention organizations and analyzed their content over 1 year. And we found that overall there were 800 skin cancer prevention messages that on average got about 100 likes and 5 comments each. That's pretty good for scientists, but obviously not reaching our audience. So what we did then was try and understand what really would motivate young women to stop tanning. How do we reach this audience, and what would convince them to change their minds? We ran focus groups with real young women who used tanning beds, and what we learned was fascinating. We learned that this generation wants facts. They don't want to be manipulated or controlled by anyone else, including doctors or professional organizations. In fact, when we ask them who they trust, they don't trust the American Academy of Dermatology, the American Cancer Society, the CDC, or even UCSF. They trust their peers, and they trust Instagram celebrities. The other thing we learned from these women is that they don't want to watch sad things. In fact, they told us that as powerful as messages about a young woman dying of melanoma might be, they would never watch it, and they would certainly never share that. And so using this input, we designed our own messages, unconventional messages, to try and reach this population. And I'm going to give you an example of what a part of this message would look like. Like I said, unconventional. If anyone's interested, that's ZDoggMD, a physician turned rapper who tries to change healthcare using innovative songs. Another great example of the interface between science, technology, and creativity. So what we did with these videos was we placed them as Facebook ads. And we targeted them to the people that needed to see them. Women aged 18 to 35 in the 5 states with the highest rates of tanning bed use and the weakest legislation protecting minors from tanning beds. And we did so precisely at the time when we needed to change their minds, and that's 1 week before prom. And what happened was that these videos in 1 week were shown 3 million times and reached 1.2 million people. And these 1.2 million people were exactly the audience we were trying to reach. So compare that, 1 week, 1.2 million women, to the top 25 skin cancer organizations over 1 year, collectively having 800 messages that get 100 shares and 5 comments, and you'll quickly see that our conventional approach, our traditional approach, isn't really having the impact it should. So I hope the 3 stories I've told you today show you why we really need to bring together the expertise and the different perspectives of technology companies, scientists, physicians, designers, the media, psychologists, behavioral economists, to try to address some of the biggest public health challenges of today. And the examples I've shown you use technology we have available today, not in 5 years, not in 10 years, it's available now. What's new is the perspective, it's the approach, it's thinking of a problem differently. So my wish for you today is threefold. First, work on important public health problems. Work on diseases that have a major impact on our population. And think about prevention, which in some cases is more important than cure. Secondly, evaluate, measure, study what you create, because by studying rigorously and developing an evidence base for what works, we can apply that knowledge to other health problems, exponentially increasing our impact. And finally, think about health equity. Design tools that reduce health disparities and do not worsen them. We want to make sure that the tools we create are accessible to everyone, not just the few that can afford them. Thank you.